Welcome. Today's presentation is brought to you by the Vermont Information Technology Leaders or VITAL and the Vermont Blueprint for Health. The purpose of the presentation is to introduce practices to the efforts in Vermont to improve data quality and reporting with an outcome of improving patient care. Without good data, healthcare systems simply can't accurately measure and assess performance. The practice of continuous measurement and public reporting creates a feedback loop that improves patient care. Quality data is accurate, complete, timely, and actionable. The quality of the data in your source system affects the information sent to the reporting entities. Quality data can reduce duplicative efforts and enhance reporting and outreach. Bad data can affect quality of care, increase cost, and put organizations in a liability situation. The overall goal is to improve the health outcomes by providing the highest quality care. In order to improve, we need to objectively be able to see where care deviates from what clinicians hope they're doing for all of their patients. The data that is used to create these performance reports is collected at the point of care in the EMR, minimizing duplication. When fed into a statewide registry, it gives practices the opportunity to benchmark against their peers locally at the state and eventually the national level. Furthermore, it identifies who is doing well so organizations can share best practices. Better stated by Dr. Kevin Larson, how do we know that care is improving and that health is getting better? We need to measure it. Measurement isn't the goal, better health is. The Vermont Health Information Technology infrastructure is designed to help practices reporting to outside entities, such as the organizations listed on this slide. In Vermont, practices enter information into their electronic health record. That information is fed up to the Health Information Exchange and merged with patient data coming from hospitals and other health systems. Within the Health Information Exchange is a comprehensive health record for individual patients, including clinical documents, labs, and some scanned notes. These are all valuable tools that can be used at the point of care. The Health Information Exchange feeds information to two additional sources, the Department of Health Immunization Registry and DocSite, a statewide patient registry. A specific, discrete set of patient information is sent from the exchange to the statewide registry, where it again is merged with information from sources such as the Supports and Services at Home, otherwise known as SASH, community health teams, and tobacco treatment specialists. Within the registry, clinicians are able to generate complex, multivariate reports on their patient population and benchmark these reports against other practices within their local area and statewide. Furthermore, the registry creates an integrated health record for each patient, including information from a variety of sources, including laboratories, primary care practices, SASH, community health teams, and potentially other community-based providers. In order for reports and patient care to be accurate, the data coming from the electronic medical record or source system has to be accurate, up-to-date, complete, and of the highest quality. The benefits of clean data are they improve patient care, they expedite clinical decision-making, prevent duplication of patient records, achieve meaningful use, enhance efficiency, reduce costs, heighten the accuracy of the records, increase the amount of information transferred to other systems, and ensure accuracy within patient charts. They improve outreach and enhance the use of the patient portal. Once again, I want to emphasize that the benefits of clean data help to improve care for patients. There are some common data quality challenges, which we'll go through individually. The provider panel, when the list of providers from an organization are incorrect or out of date. Oftentimes, patient attribution poses challenges for practices. This is when the patients are not attributed or assigned to the correct provider. Also, in many source systems, active patients are not necessarily inactivated when they leave a practice, leaving the practice's patient panel incorrect and out of date. Similarly, deceased patients are not regularly removed from patient records, which often causes potential outreach to patients' families who have already died. The clinical data, at times, isn't populating the EMR correctly or in the right place for varied reasons, which we'll review. Patient matching. This can pose challenges when a patient's health information is matched to the incorrect patient or isn't matched to them, creating an incomplete patient record. Now we'll go through some of the challenges with each of these and some of the remediation and the outcomes from those remediations. Provider panel challenges include inactive providers still being active in the source system, downstream systems not knowing that providers are not inactive or that new providers have been assigned to a practice, the National Provider Index, which is the number used to identify providers for payment and other types of care opportunities, are incomplete within the data source sending it downstream so that providers are not appropriately linked with their panel of patients or for payment. Fake providers who were created for out-of-town patients and then exported into other systems, which cause confusion. Or when the workflow or the system within a practice does not allow a practice to deactivate a provider or to add a new provider. There are some steps that can be taken to remediate these situations. Practices can review their panel and remove inactive providers. They can notify downstream systems of new or inactive providers. They can verify with the Vermont Information Technology leaders or the vendors that an MPI that was exported needs to be changed in the interface. They can determine how a fake provider is affecting the downstream system and replace it with a standardized provider type. At the time that a provider transitions, they can review their workflow and/or contact their vendor to ensure that they're able to add a new provider or inactivate a provider so that the list of providers that they have for their practice is correct. This will help to ensure that practices are paid for their active providers and that they don't receive payment for inactive providers. It also allows there to be a synchronous system of providers or accounting of providers, both in the EMR system and in the Health Information Technology system downstream, including the Vermont Health Information Exchange and into DocSite. It also will facilitate the transition of patients to the correct provider so that patient panel reports are accurate and actionable within the practice. In addition to providers not being accurate in a system, oftentimes patient attribution is a challenge. Patient attribution is the assignment of a patient to a specific provider within a practice. Specific issues arise that are created in patient attribution, including patients that are no longer active or receiving care in a practice aren't inactivated, temporary patients, those who often are coming to Vermont for vacation, are only seen once and are marked active in an EMR or electronic medical record when they actually are not an active and ongoing patient in a practice. Patients are not assigned to the right primary care provider. Patients are attributed to providers who are no longer with the practice, which is related to ensuring that you have the correct provider attribution for a practice. The practice management systems have additional attributions besides the primary care providers, like other responsible providers. There are some steps that can be taken to remediate some of the challenges with patient attribution. One of the things is to go through the electronic medical record and the practice management system to inactivate patients who haven't been seen at any point in time over the last 3 years. We can also develop systems to mark patients who are only temporary or vacationers as inactive patients within electronic medical record. It's important to ensure that all patients have a primary care provider assigned to them and that this is passed through in the exports to external systems. As we discussed earlier, we need to ensure that we have the correct patient panel and the correct provider panel within the electronic medical record so that the appropriate assignments can be made. We can also ensure that the fields are correct in the interface and mapping so that the information that is passed from the source system to downstream systems is correct. All this remediation will allow for accurate panel management reports and quality improvement measurements for the practices. It also will ensure that in patient attributions, for example, in the Blueprint for Health attributions, that patients and providers are assigned and the payments can be made so that the practice is ensuring that they're getting their entire and/or correct payments. Linked to assigning the appropriate patient to the appropriate provider is activating and inactivating patients in the SORT system. There's some specific issues that arise. Oftentimes, different systems have different rules for when to inactivate or activate patients. For example, a practice may choose a 3-year period to inactivate patients, while a health plan may use a difference of 2 years. It's important to understand both what your source system and what the downstream system is using as the active and inactive patient attribution. It's also common for sites that provide both primary care and specialty care to have an inactivated in a specialty care situation and still active within a primary care situation. It's important that the system can handle both the activation for one practice while not deactivating them for another practice. At times, an electronic health record has limitations and doesn't send the inactivated flag through in the interface, so it's not inactivating patients that are inactive in the source system in the downstream situation. Some steps for remediation include understanding what both your source system and the downstream system has in terms of their requirements for active and inactivating patients, and ensuring that you synchronize those, passing additional reports if those two things are not synchronized. It's also important to check with your organization to ensure that if you inactivate a person in one practice, it doesn't deactivate them in another practice. And finally, it's important to ensure that your flag is passing from your current system for inactive patients into the next system that you're passing the data to. All of these steps will ensure that your patient panel reflects both inactive and active patients, which will ensure that your payments and that your reporting, both for quality improvement and for patient outreach, are correct. Related to the active and inactive patients are the deactivation of deceased patients. Practices often are not aware of a patient death. Many practices rely on obituaries, which are sometimes incomplete or may be missed by a practice. At times, when a flag is provided in a practice system, it's sometimes not passed up to the larger organization, so it continues to be active in the larger organization system, not passing that deceased patient information through, which sometimes can cause an issue of the patient being brought back to life in the local practice. Sometimes also, similar to the active and inactive patients, the deceased flag is not passed forward into the next system so that the deceased indicator doesn't move forward. An example of this would be a practice takes and inactivates a patient as deceased in their EMR, but when the information comes out in DocSite, that report, which is then used for outreach, does not have that patient as having died. The result is that sometimes families are contacted or payment or other things are derived for patients who have already died. There are some remediation steps that can be taken. Currently, the Vermont Death Registry can supply a monthly list of patients who die that are from your area or from a practice. Covisint, which runs the DocSite registry, can supply this information to the practice in an Excel spreadsheet so that it can be sorted and used to deactivate deceased patients within your EMR. In addition, it is important to check and ensure that the deceased flag is passing through. You can work with Vital to determine if your exports include the deceased indicator, and if not, supported reports to the downstream system so that those practices can be deactivated in another way. The importance of this and taking these remediation steps is so that the panels that are being pulled for patients do not contain deceased patients, thus avoiding the very unfortunate situation where the practice or someone downstream is contacting the family. It's also essential for proper measurement, evaluation, and payment purposes. Clinical data challenges are often some of the things that providers fear the most. There are some discrete reasons why we have challenges with clinical data being incorrect in electronic medical records or in sources downstream from the electronic medical record. These include different codes being included in the EMR than what are used in a lab, so not being synchronized between the lab and the electronic medical record. It also occurs when non-discrete fields or free text fields are used and/or there's a combination of those that are used in the electronic medical record, which are not exportable to systems downstream. At times, practices want to customize their electronic medical record. These customized fields are often not standardized and then are not supported by downstream exports for import. Practices also sometimes choose to use autofill fields. This provides a good fit for many workflows, but at times, autofill is not appropriate for the specific data element that's being entered. Instead of as a discrete field, such as a number, the EHR treats fields like blood pressure or weight as free text, which doesn't allow it to be flowed through into the appropriate field in the downstream source system. The remediation for clinical data quality challenges often necessitate involving your local information technology person within your practice and/or your vendor. Some of the things that practices can do to ensure that their clinical data has good quality: use discrete data fields such as numbers or drop-down menu options whenever possible. Limit customizing fields into things that are not necessarily included in common data dictionaries, and to ensure that numeric values are placed in discrete fields in the appropriate way for your electronic medical record. The importance of having quality clinical data and taking the steps to clean up the quality in your clinical data is to ensure that the information that you're getting out in terms of reports is actionable by providers and ensures that the best quality care can be provided. It's also essential for analysis and evaluation of the program and of the practice. When exporting information to additional systems, as you're merging data from laboratories, from hospital systems, and practices, it's important that those patients are merged into the same health record and are not inappropriately merged into the wrong health record. Things that can cause challenges for patient matching include partial data in a patient record, such as not including the full information like date of birth, first name, last name, or social security number. The middle initial is inconsistently provided. A dummy name like Baby Girl Doe is used, which causes a false match in the downstream system. Cell phones and home numbers are interchanged. Invalid city, state, zip combinations are used. And sometimes Social Security number is not always used. Social Security number is an opportunity for a good link within the systems. Remediation steps can be taken. Understanding the keys to patient matching in the multiple systems is really important. Establishing a process for data entry for staff to ensure that the proper data is entered in the proper field. Establishing policies and processes for intermediate naming and remediation once a proper name is established. For example, when a child is born, ensuring that if you put an intermediate name, that it is later deleted. Establishing a process for data entry of cell phones to ensure good data quality. Establishing a process where the staff put in appropriate zip codes and other things, often using drop-downs for appropriate zip codes. It's important to work with your vendor to force numeric values when you're putting in things like Social Security numbers so that the Social Security number is put in properly. Patient matching is essential because once you have corrected patient matching errors, you'll be provided with a full set of data. Having the correct matches allows informed, impactful decisions at the point of care due to the availability of the patient's comprehensive medical record and set of conditions. It also allows for appropriate panel management reports that have all the information that is required for patient outreach. Once you've done the remediation, you'll have the appropriate phone number or the appropriate zip code so that you can outreach to patients when you're doing panel management. In Vermont, data quality sprints are being convened. The data quality sprints are used to clean up data within the host electronic medical record or in the process of transmitting data to the Vermont Health Information Exchange or statewide registry. It is important that all involved parties are committed to working together and attending weekly meetings to review progress and take action upon immediate items. Participation from the practices or the health system, VITAL, and Covisint are essential to promote real-time problem solving and immediate action. The result is better quality data in the electronic medical record and registry, which leads to actionable reports coming from either system. For practices who use their electronic medical record for reporting, this ensures that your reports are clean and ready for action. Who can help? You can reach out to the project manager or your practice facilitator through the blueprint to initiate a sprint. You also can speak with your eHealth specialist by contacting Vital or the registry manager, such as Vermont Information Technology Leaders, or your on-site contact for DocSite. We thank you for your time today. Hopefully this information was valuable and look forward to working with you in the future. If you'd like more information on involving your practice in a sprint, please contact Vital at the below number.